So,
Не совсем.
Вот 18, вот эти плюсики, да? Excuse me.
yes, please.
Эти плюсики, это не то, что он там говорил, 1 плюс, 2 плюса, это то, где, в каких точках мы находим, да? Эти плюсики в этой табличке, это где мы нашли изменения. Вот если у здорового человека может быть там до 50, to 50 or to 40 years old, 0 to
55.
до 55 у вас эта скор должна быть 0,2.
Слушай, речь идет только о фибрилляциях, правильно? Не положительно.
It's only about fibrillation or positive wave.
Either positive waves or
То и то.
fibrillation.
Или то, either fasciculation.
We don't know what to do with fasciculations.
Не знает, что с фасцикуляциями делать.
Okay.
Какое они там имеют.
Good
А
question.
у старше 55 допускается 4.
Yeah. So, you know, what I want you to understand is that paraspinal mapping is just enough testing. If you do less, you lose sensitivity. If you do more, you're hurting your patient for no good reason. That we have this range of normals, okay? And then we did studies with blinded observers measuring a concentric electrode versus a monopolar electrode, a little different, but still statistically significant, similar. Monopolar to another person doing monopolar was similar, and concentric to concentric was similar. The concentrics were even more, had a better correlation with each other, but they have a little bit less sensitivity. So the score of 0 to 4 with older adults with a monopolar electrode, maybe it's 0 to 3 with the concentric. We didn't do a lot of testing with concentrics. So it's still very good, and clinically, if you use a concentric, your norms won't be far off, maybe just a little bit different from ours. And as we'll show you, it can localize a root lesion and correlates with the severity of the MRI. So more questions. We talked about the S1 root. What's the difference between lumbar stenosis and polyneuropathy in the paraspinals? What can we do about neck? I haven't talked about the neck, have I? And what does paraspinal denervation do to the back? And over time, we'll try to discuss some of those questions. And then, of course, from a rehab standpoint, how do you exercise these muscles? We'll come around to some of these as we have time, but I want to leave these as questions for now. You know, if you have a central lesion, like a great big herniated disc or spinal stenosis, you'll get multi-level multifidus denervation. If you have a lateral lesion, like a lateral herniation or a lateral recess stenosis, you'll just get one multifidus. It'll be abnormal, so this is the L3 multifidus is denervated. And when you do the specific, the S column for L3, you'll find it's abnormal. But you know, in the M column down at L4, it'll be abnormal. And even maybe down at L5, it'll be abnormal in the mixed column because the muscles go down multiple levels, okay? This is Vermont, and someone is trying to sell ice in the middle of the winter. Hi. No. A little town. So the cervical paraspinals is a short discussion because we don't know what we're doing, okay?
Why?
I'll show you. I will show you. Well, we do know that normal people with no symptoms have some fibrillations in the neck. So we have these same problems with observer bias and with false positives. The anatomy, though, is way, way different from the lumbar. And I'll show you pictures, but a single level multifidus will go from a spinous process not just 2, 3, and 4 levels, but 2 and 3 and 4 and 5 and 6 levels. So a person who has C5 tetraplegia will have multifidus that's active and voluntary at T2, at the bone level of T2, because the muscle goes way down. And I'll show you the picture. Here we go. And the anatomy is also very deep. All the superficial neck muscles are really C2, 3, 4. This is not the case in the low back. And it's very small. So I'm going to show you pictures of this. Oh, and there's no proven technique. So I'm going to show you my technique. It is unproven. But first, the anatomy. I made this on the airplane. I thought this was kind of fun. So there is the multifidus from C4. You see how it goes down many, many levels? And then you think about C5 and C6. And when you want to put a needle in here, you don't know what you're in because the space that you're going in is very small space between the spinous process and the transverse process of maybe C7. Maybe that's a square centimeter. It's very small. So when you put a needle in, first of all, you're going through all kinds of C2, 3, 4 muscles before you get to little bits of each muscle. So we don't know how to get into those muscles very accurately, and we don't know how much you can poke a needle. Can I insert 5 times into a multifidus from C5? I don't know. So we don't have a range of normals. This is a study any of you can do. If anybody wants to go and get a doctorate degree in paraspinal muscles, you can do this, and I would appreciate it. Here's what I do. At bony C5, I go straight in, and I come out. I go one centimeter to the side. I go straight in and out. Why don't I go up? Because theoretically, if I go up, I could get into the spinal canal. Okay, the lamina overlap like this. And if I'm going down, I will never get in. But if I'm going up, I could get into the spinal canal. It's never happened in 70 years of electromyography, but I don't want to be the first. And then at C7, and then at T2, that's what I do. I wish one of you would do a study to prove whether this is good or bad, what the range of normals are. We simply just don't know. So this is my technique here. A short break before the next set of slides.
Okay. Would you like a coffee?
I'm fine, but do people need a break?
Yeah.
Okay. Two different talks. This next one is more about the clinical management and where EMG fits into the clinical management. And the last one is going to get into some details of some of the subtleties that you'll find as neurophysiologists. And let me get my... So what happens to older people with back pain over time? They all die. We're all done. Thank you. Well, what are we trying to do? How can we optimize their length of life, the quality of life, and their comfort with spinal stenosis? And this is really what our work is about, right? So we did a lot of research on older people and did some of the first studies looking at the functional disability in people who are older with back pain. And we found that, never mind the great details, that older people who just complain of back pain have difficulty with self-care, with mobility, with home management. A lot of older people are taking care of grandchildren or their spouses. They have to take care of other people. And some of them are still working. So we look at older people and assume that they're retired and they're still working, okay? And they have some real problems with function. The other interesting thing, you know the SF-36 for quality, health-related quality of life? Well, we looked at older people and younger people. 100 around the outside is normal for physical function, body pain, etc., etc. Younger people who've been out of work for 3 months or more have significant compromise in their quality of life. Of course, they've been out of work for 3 months or more. This is 500 younger people. But older people are even more impaired in their quality of life by pain, okay? So when we look at older people coming to our clinics with back pain, you need to think like a rehab doctor. You need to think functionally what's going on with this person's life. How is this compromising their social function, their physical activities, their mental health, right? And so you have to look very holistically at this person who says they have a backache or spinal stenosis. They're more disabled, but they're really tough, so they don't complain about it. They say, it's just aging. I'm just old. This is what to expect when I'm old. And you and I would make a very specific diagnosis. So spinal stenosis is an example. Lumbar spinal stenosis, according to the North American Spine Society, describes a clinical syndrome of buttock or lower extremity pain, which may occur with or without back pain, associated with diminished space available for the neural and vascular elements in the lumbar spine. So, a clinical syndrome. What clinical syndrome? What diminished space? And what is that association? We have work to look at. So, of course, you've seen spinal stenosis. The symptoms can vary from backache to neurogenic claudication, fixed neurologic deficit. They can have fasciculations. They can have bowel and bladder incompetence, impotence. But each of these can be caused by some other diseases. So not one of these is pathognomonic for lumbar spinal stenosis. Classically, these symptoms are relieved on forward bending. But of course, facet joint pain is also relieved with forward bending. And as we've shown in the very first study of MRIs, about 65% of people who have no symptoms look like they have moderate to severe radiologic stenosis on an MRI. The Framingham study looked at a large population of older people in CAT scans, and about half of the population of Framingham, Massachusetts, that is over the age of 55 looks like they need back surgery. Clinical spinal stenosis is common, but we don't actually know how common. And in our country, it's the most common cause of surgery in older people. And I know that as your population ages as well. So what is that clinical syndrome? Have you heard this complaint? Doctor, whenever I lie down in an MRI scan, my back and legs hurt? Anybody? Whenever I lie down in an MRI scan, my back hurts? That's not what they come to you saying. In fact, they come saying the opposite. When I lie down, I'm okay. When I stand up and walk, I'm in trouble. So do we get an MRI scan while somebody's walking? No. Does it make sense that an MRI would detect something that is not symptomatic when they're in the scanner? No. The other one is, I'm a surgeon, damn it. Top of my class, smartest student, trust me, I know stenosis. In the United States, we also know that the surgeon makes 3 times my income by knowing stenosis. And in our country, and by the way, a lot of the research on stenosis comes from my country, okay? In our country, the chances you get a back operation are different 10 times more in one town than another. It correlates not with pathology, it correlates with how many surgeons live in the town and how many MRI scanners are in the town, not with the disease. So what you read from the United States about stenosis is horribly corrupted by the fact that surgeons make 3 times my income by operating, and they look at the scan. And then, of course, we have these conventions of the North American Spine Society convened a group of our friends and came up with that definition I showed you, which they pulled out of a hat. They did not come up with a specific thing. Well, so we did a scary study. We took a bunch of people who were offered surgery by one of our University of Michigan surgeons who are very conservative, good surgeons. We gave those cases to another surgeon at the university who could not look at the MRI scan. And 1 out of 5 people that our surgeons had offered surgery, the other surgeon who didn't look at the scan thought they were an asymptomatic volunteer. So one surgeon's offering surgery, and the person who's not looking at the film thinks that they're a volunteer who is an asymptomatic volunteer. Between our 2 different surgeons, they had a 16% disagreement as to whether stenosis was the problem. Okay? Again, we didn't let them look at the scans. They had to look at the patient and get this clinical syndrome. Okay? Now, there was some real agreement. There is a sense of what the syndrome is, but the disagreement is 16% between whether they operate on your mother or leave her alone is a little scary. Huh? So this is our Michigan spinal stenosis study. $1 million from the National Institutes of Health. Crazy. This is the first study of spinal stenosis imaging that actually included a control population. Okay? And we had 2 groups, as I said. We had asymptomatic volunteers and people with mechanical back pain. This at that point was the largest study of MRIs in asymptomatic older people done. And it was the very first study in history of electromyography that was blinded, where the electromyographer was not allowed to know anything clinical about the patient. And we did some work to validate the blinding. So when I did an EMG in this study, I truly didn't know whether it was an asymptomatic volunteer, mechanical back pain, or what looked like neurogenic claudication. We followed up a year and a half later. As I said, we tried to get a population with mild to moderate stenosis, people that weren't headed to surgery, so we could see what happened over time. So the clinician, we had a clinician who was blinded. Well, we recruited people as mechanical stenosis or asymptomatic, but that's not how we categorize them. We then had a clinician look at the patient and decide, yes, this really is just sacroiliac joint. This really is just neurogenic claudication. And then we brought them into the blinded study. We did a lot of work, by the way. We would not include anybody who looked like they had a polyneuropathy, and this is important. I'll come back to where you will find use here. So if you were diabetic, if you drank a lot of alcohol, if you had a known polyneuropathy, other things, we excluded you. And the clinician who defined the case was asked specifically, is there a polyneuropathy? No. And when they said no, then they were included in the study. So we did the best we could clinically to say that there wasn't a polyneuropathy. The MRI scan was done. The radiologist didn't know what was wrong with the patient. The EMG was masked. And we did a bunch of function and pain questionnaires. And we repeated everything at about 18 months or more. We talked about that. So first of all, isn't it interesting? You say, how far can you walk without stopping? And when somebody says they could walk 15 meters, they could actually walk 400 when we had them walking in our hallways. So the patient's report of what they could do was not accurate. What they can do, remember my international classification of function, which looks at function and activity and participation, right? So what you can physiologic do isn't really what they did during their course of their life. So we did the very first studies using pedometers. This is before activity monitors, right? And we looked at how much people walked in the course of a week. And we found, in preparation anymore, that all of the tests of walking, the questionnaires about walking, correlated with their capacity, their 30-minute walking distance in the laboratory, but very little correlation with what they did during their daily life. So again, our measures of can you walk don't relate to whether they did walk. What's the difference? Well, if you only have to walk to your mailbox every day, you don't walk far. And if you get neurogenic claudication at 100 meters, but you never have to walk 100 meters, should we operate on you? No, it's not affecting your life, okay? If you live in a bad neighborhood, if you're unsafe for other reasons, you won't walk much. And so the actual walking performance in life is what we're trying to treat here. We're not trying to treat their capacity. We're trying to treat actually what they do in their lives. And the questionnaires that we use, the standardized validated questionnaires, aren't validated in relation to real life. So, okay, we got this down. So let's talk about diminished space. Did anybody here ever take a statistics class? Statistics? Parametrics, non-parametric statistics? Okay, yeah. Some. Mathematics, yeah. So let's think. Diminished space, you can measure the canal diameter. You can measure the fecal sac diameter. You can measure the area of the canal or the area of the fecal sac. You can measure the interligament distances, this has been reported. You can measure the lateral recesses in the foramen. And then, of course, you're looking at changes related to age and body habitus. And then 8 different measures at 5 different levels, and you use a cutoff of p less than 0.05. Statistically, you need to make what's called a Bonferroni correction. You need to say you can't use p less than point. It's like flipping a coin 100 times and it turns up heads 5 times in a row. Well, if you do it 1,000 times, I promise you it'll happen just by chance alone. So the measurements that we all learned in school about 12 millimeter canal or 9, is relative stenosis, and 9 millimeters is absolute stenosis. These things we learned in school, they came out of studies of spines of dead people and their means and standard deviations. And somebody decided there was a 5% cutoff, and then they measured it many, many, many times. It's like flipping a coin 100 times and finding out you got heads many times in a row, okay? Statistically, everything we learned is impossible, okay? If you use all these different measures and try them on every spine, just mathematically alone, 50% of people look like they need surgery, and that's actually what happens. So the diminished space in the spinal canal is not a definition that we can use from this North American Spine Society. Yeah, so by chance alone, half of people will look like they're abnormal. So the association between symptoms and space. Here's our Michigan spinal stenosis study. 3 groups of MRIs. People who are asymptomatic, people with back pain, and people with neurogenic claudication. One of these groups needs surgery. Which one? See the canal diameters down here? And by the way, fecal sac measures, etc. had no use whatsoever. So this is the best you can do. Where do you move this red line and say people to the right side need surgery, people to the left side, the smaller canals, need surgery, people to the right side are asymptomatic volunteers? What is the discriminant value of the MRI? And the answer is there's no place you can make that line and statistically be right about whether somebody has clinical symptoms of stenosis. Now it turns out that the stenosis people have slightly smaller canals on the average, but the discriminant value is 0. Let me translate that. MRIs are useless in finding pain in older people. They are useless. They have no use. Now here we're talking about spinal stenosis. They are useless, statistically shown to be useless. But when you study spine, you find out that facet joint changes and disc collapse and annular tears and anything you can find in the spine on an MRI in older people has no statistical relationship with pain. Cancer, infection, fractures, of course. But when you look at a person who doesn't have cancer, doesn't have an infection, doesn't have a fracture, and you look at your MRI, well, don't. It cannot prove this person hurts compared to being a normal subject, okay? And this is the problem, because our surgical colleagues will throw up the scan and assume they know what's wrong. So we cleaned up the syndrome thing. What is this syndrome? Well, you know, syndromes are a political thing, right? A global society, a surgical society, or an endocrine society, or a psychiatric society will say, you know, this is the DSM-5 diagnosis for a major depression, right? This is our society's political decision. It's based on science, but it's a political decision. So we didn't really like the idea that a group of expert, mostly surgeons, spine doctors were defining a syndrome in such a vague way. We thought it needed to be done by the experts from all over the world. So we brainstormed on things that could be defining the syndrome. We added a couple of irrelevant choices just to make a more valid study. We created an iterative process where we'd ask, a person comes into your office with a complaint of back and leg pain, what's the first thing you'd ask? What's the second thing you would ask? What's the third thing you would ask? And we crowdsourced the answer. We first did this with a bunch of American rehab doctors, but then actually we got the International Spine Society's Global Award a couple of years ago. We did it with 249 in all of the related specialties and came up with what you all think spinal stenosis looks like. Not what some committee of a spine society, but what you all think looks like spinal stenosis. And what we found is this. Most of the people thought leg and buttock pain, flexing forward to relieve pain, using a shopping cart or a bicycle was easier than without, motor or sensory changes. A normal foot pulse was kind of important, weakness was kind of important, back pain not very important, and then these other things like do you have thyroid disease, which shouldn't count, right? So these all together get to an asymptote. More questions did not really result in more certainty among you, among the 200 experts, right? Their certainty, though, after asking all these questions was only 80%. Nevertheless, for the very first time, we came up with a measured definition of the syndrome. And so if you were to ask all these questions and somebody qualified, you'd be about where 80% certainty that other clinicians would think somebody had stenosis. That's a syndrome. That's something that we've defined as a set of symptoms that relate to each other, okay? It's not a disease, by the way, it's a symptom. Is 80% good enough? Of course not. And this is where your EMG begins to become important. By the way, our clinicians' diagnosis, when we followed people for 18 months, people that initially were thought to have stenosis, 2 of them at follow-up were thought to be asymptomatic volunteers. People that were initially thought to be asymptomatic volunteers, at 18 months follow-up, 3 of them looked like they had stenosis based on clinical history and physical examination. It's kind of junky. It's kind of not so clear what's going on here, right? You need to be very humble about our clinical history and physical examination. It's not that great. Let's see, okay, here we got these. So we also looked at what did predict somebody getting worse, because the folklore is you have spinal stenosis and you're a healthy 70-year-old, you might as well get surgery because when you get older, you're going to be in more trouble, okay? Now there are studies before ours that say that's not true, that some people with stenosis do get worse. We've all seen that. Some people stay perfectly stable and some people actually get better over time for all kinds of reasons we can get into. So we found that the pain at the onset didn't predict anything later on. We found that the physical examination, changes in reflexes and strength at the initial, like weakness, initially did not predict how somebody was doing 18 months later or 2 years later. The MRI measures, which didn't predict what was happening at the time, also didn't predict what was happening in the future. EMG, if it was profoundly abnormal, it predicted whether somebody was going into trouble, but not so great. Some findings on EMG does not predict that somebody's going to be worse or better later on. Their current disability predicted their future disability. Their pain disability index, which is a very specific scale, predicted itself. And their ability to walk predicted their ability to walk and also their level of disability, right? So when somebody comes to your office with what you believe is clinical stenosis, well, it's really their level of disability that predicts everything. Their difficulty walking that predicts everything. Not the MRI scan, not even your EMG unless it's really quite profound. And I forgot this. Sleep problems predicted future pain. Now, sleep is probably a marker for depression. I don't know. We didn't measure depression. But there are obviously psychological or social or some other factors that relate to sleep that might be the reason why people who did poorly with pain down the road had less sleep, were sleeping worse. So this was our protocol. You know, we had these 150 people that we screened, and when we did the EMG, we had to kick 8 of them out of the trial. So 8 people who came into the study screened against neuropathy, the blinded electromyographer found slowed conduction or distal fibrillations or other things that ended up having to meet criteria for polyneuropathy. My favorite case was a lady named Catherine Koski, and she actually showed up on the national news because somebody found out about this. She was a 72-year-old woman who had low back pain and leg pain and a foot drop. And her MRI showed spinal stenosis. And her nerve conduction velocity was 20. She didn't know it, but she had Charcot-Marie tooth. Huh? And they were going to operate on her Charcot-Marie tooth disease because her MRI looked funny. This is why your test is so important. So and these are people that are screened. These aren't people that, we looked for alcohol or diabetes or did you have neuropathy. No. She's got a foot drop. The doctor, the rehab doctor that was looking at the case said, this is a stenosis case. She qualifies. And the EMG is the only test that prevented her from getting surgery. A couple others didn't know they were diabetic. When we found the polyneuropathy, their doctors found that their hemoglobin A1C was elevated. A couple others we don't know because we weren't allowed to follow all these from a research protocol. But your first job with a spinal disorder is to make sure it's not a polyneuropathy because the clinical exam of some expert doctors is not so great. Then we had this population, which we talked about, the different groups. In this population, the paraspinals were discriminant. Remember, our MRI was not discriminant. Fibrillations had this sensitivity and specificity. The paraspinals were less sensitive all by themselves, but very, very specific. When we took a perfect population, we had a neurosurgeon review the cases and say what really is going on with a scan, everything else. And we had a much smaller population where the surgeon, this clinical examiner earlier, and the MRI all said the MRI is useless, but they all said it was stenosis or not stenosis. We did that because the North American Spine Society and some of the journal publishers insist you can't call it stenosis unless you show us there's an MRI finding. So we proved the MRIs didn't work, but we had to do a study that included MRI findings, right? So now here the surgeon, the examiner, and the MRI all concur. It's a smaller population. But look at this. Abnormal paraspinal muscles, 100% specific. If the paraspinals are statistically abnormal, they have spinal stenosis, right? This is where your test is much better than the MRI scan. What you find is much better than the MRI scan. So, you know, is the only EMG findings, by the way. If you just do a limb exam and do the paraspinals only when you find something in the limb, you're going to miss 40% of people who had symptomatic stenosis in a positive EMG. So I actually do the paraspinal first. It gives me the answer almost always, and then the limb is just to clean up, to look for other problems. You got to use our normal values. You can't just say the paraspinals have fibrillations. You have to come up with a paraspinal mapping score. Otherwise, it doesn't work. In fact, I think my next click is, yeah, when the electromyographers gave us their impression, it didn't work. The electromyographer's impression was not predictive of symptoms. When we went back and looked at their impression and looked at paraspinal mapping score, it's because they scored paraspinals not using our technique. They used our technique, but they didn't use our normal values. They just said, oh, there's one train of positive waves, it must be stenosis. When we got rid of those cases where they were doing it wrong, then all of a sudden the EMG as a whole was predictive of the clinical syndrome. So you've got to use the paraspinal mapping scores. As I said, the sensitivity, we excluded surgical cases. My friend Yagsigi is a Turkish guy who we became friends because he copied our study. But he did it in people who were headed to surgery. Paraspinal mapping alone was 93% sensitive for people going to surgery. Sensitivity depends on the severity of the disease, right? Now, I actually don't care if the paraspinals are abnormal in most of the people I saw because they had mild to moderate disease, they shouldn't get surgery. But when it comes down to people where your surgical colleague is asking, you know, I think I need to operate, they ought to have a positive EMG, okay? And it's not perfect. I have had people who had neurogenic claudication, and I was very clear they had spinal stenosis, and I had a negative EMG. It's not perfect, but it's pretty uncommon to have a negative paraspinal mapping and a negative EMG and still have a other work people have done, and it's kind of neat because people around the world have started copying us and doing things. These are a bunch of older women who had small spinal canals, right? And the people who were asymptomatic but had small canals, and the people who had symptoms. Look at their paraspinal mapping score compared to the others, right? It's pretty high. It's very clear that these women with small canals, you can differentiate between asymptomatic and symptomatic volunteers. This is, by the way, on both sides, so 4.59 divided by 2. You know, they combine them together. The symptomatic group, the positive paraspinal group, also had worse balance, static and dynamic balance. So the EMG predicted their functional difficulty as well. Group of surgeons in Asia wanted to operate on the spine, and in some cases, they just used the MRI. In other cases, they did paraspinal mapping and used that to help guide their operation. Paraspinal mapping lowered the number of levels they operated on, their surgical time, their blood loss, and how many transfusions with the same clinical outcomes, okay? So when somebody's planning on doing surgery, I don't know that you always have to do an EMG, but indeed, for complex surgery, the EMG can inform the surgeon about where they should operate and minimize the number of levels they need to operate on. Bunch of people with unilateral, one-sided radicular symptoms did paraspinal mapping, and they treated them for the course of a year. People with positive paraspinals didn't get better. People with negative paraspinals got better, okay? So again, if they've got negative paraspinals, it probably isn't a herniated disc, it was a misdiagnosis, or was a very mild one, or something that's very short-acting, right? So the paraspinals are also a predictor of future outcomes. If paraspinals are abnormal, you may be heading into trouble. A long time ago, we looked at an important question, which is an EMG just a test, or is it a consultation with an expert doctor, where you use the history and physical examination? So we did a study in the back and lower limb EMGs, and we did a comprehensive history and physical examination, and then did the EMG. The EMG didn't clarify what was going on in about a third of the people. In about a third of the people, our first diagnosis was wrong. Our second or third differential diagnosis was right. So we said, I think this is a polyneuropathy, but it could be a herniated disc. Well, it ended up with a herniated disc, a radiculopathy, okay? I think it was 5%. We found something completely different from what we expected. You know, I thought it was radiculopathy, but it's amyotrophic lateral sclerosis, right? And so it decreased the differential diagnosis. In the upper limbs, we did more detailed study, and obviously your history and physical examination predicted what happened during the EMG and predicted the interpretation. So clearly, you are not just a technician. Your clinical impression is driving how you do the test. You're not just driven by protocol. And the same thing, I think a third of the cases we changed the diagnosis, 5% it was a diagnosis we hadn't even thought of. So here's a summary technically of what we just said. You have to do paraspinal mapping in the low back. You really miss so much if you don't. 6 limb muscles, good idea. H-wave will detect things that the needle exam doesn't. Sural sensory to make sure you don't have a polyneuropathy. Peroneal motor to look for the fibular head. And then you look for trouble elsewhere, right? Clinically, what did I say? These tests are useless. Don't let anybody look at a scan before they examine the patient. Don't let people get an observer bias. The scan looks bad, now I'm going to convince you that you've got claudication. Spinal imaging does not address the differential diagnosis. There's no MRI of the spine that's going to find a tumor in the lumbar plexus. There's no MRI of the spine that's going to find a polyneuropathy, right? There's no MRI of the spine that's going to find a peroneal nerve lesion at the fibular head. So spinal imaging is held as a gold standard by our colleagues, and it's your EMG that's most important here. And EMG can find these surprises. And as you guys all know, it's safe. In 70 years, the only complications ever have been punctured lung, and we don't have punctured lungs in the low back, so that's okay. There's never been a meningitis. There's never been a cerebrospinal fluid leak, at least never in the literature. And I've asked people for 20 years, have you ever seen a complication? So it's a very safe test, but it requires expertise. Last part of this is, okay, so who cares? There's a scandal, which is when we submitted that paper, the very important paper, to the Journal of Bone and Joint Surgery, it was accepted by the reviewers, and the associate editor declined it and asked for revisions 7 times over the course of a year. And the revisions contradicted each other. And they were delay, contradiction, take away important things. And at the final revision, they made us make 100 more corrections. And without our permission, they said that this double-controlled masked trial was neither controlled or masked, and it was level 3, like anecdotal evidence. During the course of that year, the North American Spine Society came up with their practice guidelines. And later on, our group. So one of the editors of the Journal of the American Medical Association heard about this and asked me to write a commentary on how to treat spinal stenosis, basically to make these people shut up. And so we have this nice little commentary, which is a good roadmap for how to treat spinal stenosis. It's a fractal iterative process. It depends on what goes on. It's not simply you have stenosis, you need a test. So first job is to find and treat what's not spinal stenosis. You know, as we talked about, radiating pain is not always stenosis. My funny rhyme, peripheral vascular disease, polyneuropathy. There are other disorders that can modify the person's ability. Depression. They don't walk because they're depressed. Deconditioning. The amount that a person walks with stenosis related to obesity, not to their level of stenosis. So obesity is a disease that's not treated with back surgery. And there are other disorders that can limit a person's function so that it doesn't matter if they have stenosis. If they've got heart disease, if they got polyarthritis, fixing their stenosis is rather foolish if you're not going to improve the quality of their life, right? And there are social factors. If they live in a dangerous neighborhood, they're not going to walk. So you have to look at what's not stenosis. Then you find and treat the effects of the stenosis. So rehabilitation is different from physiotherapy. When a person has a spinal cord injury, we don't try to cure them with physiotherapy. We try to rehabilitate them to get out and play basketball despite their spinal cord injury. So of course it's great to have physiotherapists try to treat the stenosis, but take a look at their function. Do they need assistive devices, a cane? Do they need a wheelchair? Are there architectural barriers? Are there coping skills that they need to improve? Are there lifestyle strategies that you can improve on, right? And then you don't need to prove it's stenosis to do some of the things. Uh-oh, we just froze up again. Come on now, here we go. You can treat the stenosis without proof. Physiotherapy, there's very little research that says physiotherapy works. It probably helps in some ways. Ambulation, what we did a study, Agnes Waldbaum and I did a study, making them walk distances actually helps them improve their distance walking, even though they have neurogenic claudication. Paraspinal muscle strengthening can probably help. Hip flexion contractures are really important. So take a look at me here. If, I'll come up to my spot up here. Yeah, hold on. So, if I have spinal stenosis, I try to bend forward. It opens up my spinal canal. I can walk further, right? If I have a hip flexion contracture, I have to bend even further forward, right? If I got a 90-degree hip flexion contracture, if there's nothing wrong with my spine and I sit around like this all day long, you think I'm going to get a backache? Right? So if my hips are tight, I've got to do this so I can see the world, and I'm making my canal artificially small, right? So older people, especially who sit at, like all of us doctors who sit at desks and don't stretch so much, they've all got hip flexion contractures. You straighten out their hips, and now a flexed posture is actually a normal posture, right? By the way, when somebody has a hip flexion contracture, they're jamming their facet joints and their sacroiliac joint, and they complain of back pain. Nothing wrong with the facet joints, nothing wrong with the sacroiliac joint, but if I'm doing this all day, they're going to hurt. So now they have back pain and leg pain. It's a mess. If anybody knows physiotherapy, hip flexion contracture is just little. There's all kinds of other mechanical things you can do to try to get someone so that their spine canal is more open and they have fewer symptoms. Manual physical therapy, not proven, probably helps. Manipulation, unproven, maybe helps. And there are all kinds of alternative treatments that don't require proof of spinal stenosis. Pills are dumb. Doctors like pills, and that's dumb. When you're dealing with chronic pain, the best in the world is 30 to 40% pain relief with medicines for long-standing pain. And most of those studies haven't followed people for more than a month or so, and they declare victory, right? So you have somebody you put on amitriptyline or gabapentin, and they're on it for 5 years. There's no study that says that helps, okay? And if it does help, the best studies say at 1 month, 30% pain relief compared to placebo. But with older people, look at all the medicines we use. Non-steroidals, acetaminophen affects the liver in older people. The opioids, falls, depression, sleep dysfunction, constipation, addiction. The muscle spasm pills, I don't know a pill that gets rid of muscle spasm. I do research on muscles. So the drugs that have been shown to you to relieve muscle spasm do not relieve muscle spasm. Carbamazepam maybe here, what's Robaxin, a whole bunch of other medicines marketed as muscle spasms drugs have no effect on muscle spasm whatsoever. Drugs like diazepam affect spasticity, but muscle spasm is not an upper motor neuron syndrome. Muscle spasm is more like a cramp. And if you get a cramp in your calf in the middle of the night, do you take a pill? No, you stretch out the calf, okay? The drugs that are marketed to help with muscle spasm have no direct effect on muscle at all, and they increase falling, so I find them relatively useless. They're on the market because they've been shown to help with pain a little bit. And in the newer pain medicines, the amitriptylines, the gabapentin, the pregabalin, Lyrica, those help, but they all have their own complications too. So they're not stupid, but realize the limitation. If you or the patient thinks a pill is going to get rid of more than 1/3 of their pain, then I don't know what drug you're taking, because it's just not in the literature to have a medicine help very much. Use them, but not as such a big cure. Step 4, treat the anatomy. And here's where spinal injections, epidural injections, we don't know why they work for stenosis. It's not an inflammatory process, but they work. The risk-benefit ratio is a little bit different because older people getting surgery for stenosis is a bigger risk. So just try them. EMG, by the way, another study that our group did, and then some other studies came out with it, show that the paraspinal mapping predicts outcome from epidural, and it localizes the lesion to tell the doctor where to do the epidural, whether it's a transforaminal injection at L5 or L4 can be defined by your paraspinal mapping. And then you also assume in stenosis that any back pain in stenosis is not coming from the stenosis. The horrible, horrible back pain with a little bit of neurogenic claudication, the back pain is facet joints or sacroiliac joint or some other mechanical cause, which is treated differently than a multi-level laminectomy, right? Here, let's see, we go. So these other things are very important to treat that are not stenosis. And then sometimes we think if you inject the facet with steroids, it decreases the inflammation and helps too. So, and then surgery. This is where you must do your EMG. We've shown this, the inter-rater reliability, et cetera, right? The injections should be done before anybody considers surgery for stenosis because they work. Not always, but they work. Consider the physical therapy, occupational therapy, psychologist looking at the patient and coming up with ways for the person to live a better life despite their stenosis. And be sure the patient doesn't think their stenosis has to be fixed. They come to your office with an MRI scan and look at how tight, look at the doctor said, the surgeon said, you know, make sure they understand that no, it's okay. You decide how badly this affects your life. And then you can provide this truly informed consent. And then truly, surgery is a good idea. I'm not against surgery. If somebody has failed all these other things, surgery is a really great treatment for stenosis. I think it's a high quality procedure. The end game though is, you know, people live with disability. My patients with spinal cord injuries and brain injuries and strokes and amputations live with disability. We don't have to fix them, we can hurt them. But now, you're considering surgery, but you've treated all the reversible causes. The EMG hopefully made a positive diagnosis. It's ruled out other things. And the patient's really ready for surgery, and the outcomes for the surgeon are better. The MRI helps the surgeon decide how deep to put the knife, not whether to put the knife in, right? The MRI helps with the technical aspects of the operation, not whether or not an operation should be done. So that is almost the last talk. Everybody gets 1 second to stretch. We'll come back to more technical stuff. Number 4.
Следующая будет лекция. Потянитесь, он сказал. Точно, давайте потянемся. Последняя будет вот как раз та теоретическая часть, о которой мы его очень просили. Вот этот мэппинг, то, что он там прошелся очень быстренько, да, по мультифидус, вот это все. Вот это будет посвящено именно этому.